in intra-arterial therapies, extrahepatic supply, and flow diversion.
Thank you guys so much. It's an honor to present here in Egypt. I will be talking about the technical challenges in intra-arterial therapies. These are my disclosures. The intra-arterial therapies are evolving into personalized treatments, as multiple speakers have mentioned previously. This is especially true with all the evidence that was presented in Y90 and the efficacy with complete pathologic necrosis and decreased toxicity in the setting of radiation segmentectomy. However, when we do these treatments, we have to realize that sometimes the tumor's angiosome can limit selective delivery and cause toxicity to non-involved liver. And so what I mean by a tumoral angiosome is this kind of classic case that you want to see for a radiation segmentectomy. We have a nice, about 3 centimeter lesion in segment 5. We have a single feeder, and we have a secondary artery supplying a portion of the same segment, which can be sacrificed, giving a total treatment of about less than 10 to 15%. When you compare that to this patient who has a TIPS, has some refractory ascites, and has about a 5 centimeter tumor, all of a sudden, all that normal parenchyma that you are worried about can become a problem if you're doing high dose radiation. When you do the angiogram, you can see that there's definitely multiple feeders. We'll close in on these. We got one coming from the posterior segment, we got another one from a different branch, and then a third branch coming from the anterior segment. You can look at this here. You can see that there's definitely a portion of the tumor coming on cone beam. When you look at the other part, that's the other part of the tumor. So how do you treat this? Do you do high dose radiation to the entirety of the right hepatic lobe and have to take into account that the patient has a TIPS? So the key challenges that we face when we're doing this personalized treatment is anatomic complexity, arterial variance. Are we going to get adequate tumor coverage? Is tumoral supply overlapping normal parenchyma? And then we also have to search for extrahepatic supply. So what are the consequences of these challenges you face? Well, you can have non-target embolization, again, inadequate tumor coverage, increased complexity, increased cost. And so not every patient looks like this. We have some patients that look like this. So now you have bilobar disease, you have small arteries, multiple tumors. You can't approach that in a similar fashion to the prior case. Another case like this, you have predominantly right-sided disease, and then you have a lesion sitting up here under the diaphragm very far. You can make the argument to try ablation, but I'm as adventurous as anybody about ablation, but I didn't really feel like that would be the best for this patient. And so we'll kind of talk about some strategies. These include super selective catheterization, extensive use of cone beam CT to find small branches. If you have the ability to use a CT angio suite, those are great, even more detailed imaging. Or embolization of non-tumor parenchymal feeders, i.e. flow diversion. And so flow diversion is intentional embolization or occlusion of vessels supplying non-tumoral parenchyma. It can be done with detachable coils, microvascular plugs, balloon microcatheters, gel foam, either in slurry or pledget form, or pressure-enabled drug delivery devices. This term was introduced in multiple little case series. The biggest coming out of Mayo Jacksonville that looked at embolizing normal parenchyma to cause diversion of Y90 into tumors, and they found that in about 40% they could actually decrease the dose by about 40% in their study. And so we have this problem. We have this patient that's got metastatic colorectal cancer. They got predominantly right side, but that left-sided lesion. And when you do your angiogram, you notice that the segment 4 artery is coming off the segment 2 artery, which feeds this tumor right here. And so when you do your mapping, you see that most of the uninvolved liver will also be a problem with uptake. So how do you solve this problem? Well, I decided to get 2 accesses. We got a proximal microcatheter in segment 4, and then I placed an MVP plug, did not detach it, and delivered the proximal dose to the right lobe tumor. From there, I pulled out this catheter, left the MVP plug in place, removed the MVP plug, did an arteriogram. The artery was completely patent. There were no issues. Delivered the low selectively. And this is the post-MAA spec from the case, and this is the post-Y90 spec showing that we were able to significantly decrease the amount of material that was deposited in normal liver. Now, I realize that MAA is not a perfect surrogate, but that's kind of what we have. What are some of the risks? You can have a hepatic infarction or parenchymal ischemia. You can recanalize or have collateral recruitment. It increases the complexity of the procedure, increases procedural time, fluoroscopy cost, and it can cause unpredictable flow dynamics. Sometimes proximal occlusion, you'll get collateralization immediately, and it's kind of unexpected and unpredictable, basically. Just kind of touch a little bit about extrahepatic supply. It ranges in you see it in about a third of patients, and there's a vast number of parasitic supply that precludes us to identify all of these during the cases. And not recognizing can have recurrence risk, as well as if you treat it and don't take account of the complications, you can have severe issues. Kind of what are some of the factors that induce extrahepatic supply are listed in the chart there, with the most common actually being multiple prior sessions of TACE. The most common origin is the right inferior phrenic artery, as you can see here, and so we got a pretty large tumor. This is the angiogram during the mapping portion. I embolized it using a gel foam pledget, delivered my Y90 dose here, and this is the results at 3 and 9 months. And just kind of another case, this is a exophytic tumor arising from segment 6, and you can see that there's some mesenteric feeders which were not able to be selected. I was not really going to embolize these because it was going to be too hard to get to. So did a combination TACE ablate in the same session, and this is the result at 3 months. And then just kind of another case. This is a this is a recurrence at a site of prior ablation. You can see the main lesion here and then a lesion in the liver. The angiogram of the right only found this area here, so we did a renal angiogram and found a capsular branch that was feeding the tumor. Another TACE ablation combined, and this is the results about 6 months later. So in conclusion, vascular supply complexity is a fundamental challenge for intra-arterial therapies and in hepatic malignancies. With flow diversion, is a viable strategy to help tumor targeting, and successful implementation requires meticulous planning and mapping prior to treatment. Thank you.
Okay, thank you very much. The next speaker is Dr. Osama Hetta. We'll talk about challenging case for ablation.
Good morning, everybody. At first, I would like to thank Professor Ahmed Kamel and the organizing committee for the invitation and for this excellent organization. Allow me to change the title of modify the title of my talk, Thermal Ablation of the Liver in Difficult Lesions. So, HCC is the 6th malignancy worldwide and the 4th cause of death or malignancy-related mortality. For this reason, all potential curative therapies like ablation, transplantation, and resection should be utilized as first line of treatment whenever feasible. All the academic societies and all the guidelines accept ablation as a curative modality, especially for patients with a poor hepatic reserve and operation could not be done. And the well-known BCLC classification in very early stage BCLC, we consider ablation for the treatment. In last decade, technical advancement and technologies in the ablation, also this is combined with percutaneous ablation technique improvement. So this new scenario open up new frontier in ablative techniques with possibility of going beyond traditional clinical indication. What is the advanced thermal ablation techniques? Basically, we have this monopolar radio frequency with ionic agitation, frictional heat, as you all know, but the monopolar radio frequency has some limitation. The heat sink effect, it's not compatible with pacemaker, with possible thermal injury when the lesion in spatial sites near to the common bile duct, the bowel loops, and so on. So we have new needle types like jet needle to make a large a volume of ablation, and expandable needles also to cover large tumors, and recently cluster internally cooled and bipolar or multipolar radio frequency ablation. With this multipolar electrodes, there is sequential activation of two separate electrodes that lead to centripetal diffusion of heat, controlling the extent and the shape of ablation, so we can upgrade the size of ablated area with possibility of no-touch technique to avoid sealing. And also in this multipolar RF, we have no grounding beds, and it is compatible with the pacemaker. We can get this large area of necrosis and large tumor with multipolar RF electrodes. So we have different options of electrodes of RF, expandable needles, multipolar, cluster electrode, and so on nowadays are available. More recently, the microwave ablation, the relatively recent technique, which have heats more than radio frequency and making larger area of ablation in a short time with no heat sink effect, no grounding beds, and also it is compatible with pacemaker. So using these technologies, combine it with advanced technique, we can maximize the therapeutic effect of ablation and reduce the complication. To maximize the therapeutic effect, we have some challenges: the size, the site, and the visibility of the tumor. As regards the size, classically RF is used in tumor less than 3 centimeters, but with use of multipolar, microwave, and the recent electrodes, we can upgrade the size of the ablated area more than the 5 centimeters. Again, sometimes we have lesions in difficult sites like subcapsular lesions like this. We can ablate by accumulation of experience. We can ablate this subcapsular lesion and this one also with a nice area of necrosis after ablation. Consider the coagulation profile. Don't puncture the tumor more than one time, and some precaution to get this beauty response. Also, lesion in the dome of the liver, like this lesion, we can ablate safely, provided that you can see well by ultrasound the we can see by ultrasound the tip of the needle. Look here, we ablate beside the heart, and we can get the necrotic area on the right-hand side. The pleural effusion following ablation in the dome of the liver is accepted, and it is resolved by medical treatment or conservative. Again, lesions adherent to the gallbladder, we can ablate safely, provided that you go by needle. You can see its step precisely and calculate the ablated area. And in thyrotic background patient, the wall of the gallbladder is fibrotic, so it protects the gallbladder. So lesion adherent to the gallbladder, we can ablate it safely, as you see in this case, with a very nice area of necrosis on follow-up. Lesions near the bowel loop, we can ablate by radiofrequency alone, and sometimes we can do artificial ascites to get marvelous response like this. We ablate precisely beside the bowel loops. To get such area of necrosis. Tumor visibility can also achieved by contrast-enhanced ultrasonography or fusion images of CT and MRI pre-ablation with ultrasound to improve the visibility on the tumor. Again, combined treatment can upgrade the size of the ablated lesions, and this will be discussed in details in the next lecture. How to avoid and manage the complication? Tumor seedling can be avoided by good track ablation and no-touch technique by the multipolar electrode. Liver hematoma, hemoperitoneum, and hemophilia can be avoided by checking precisely the coagulation profile and not to puncture the lesion many times. Ascites and liver failure avoided by proper selection of the patient on background of liver function. Infection and liver abscess avoided by prophylactic antibiotic, and in case of pacemaker, we can use microwave or bipolar radiofrequency electrode. Bile duct injury also avoided by using another technique for ablation, either chemical ablation by BAI, IRI, or TACE enlarger lesion. So, the role of thermal ablation has increased in recent years due to technical advancement allowing ablation of larger tumors in a short time, advanced technique allowing ablation of at high-risk location lesions, combination with transarterial treatment improve outcome and treat intermediate stage HCC. And the result is improved survival rate, allow targeting larger tumor, expanding the number of treatable lesions beyond traditional clinical indication. I would like to invite you all next month, 22-23, to the IG Look conference with the interventional radiology track organized by Egyptian Society for Interventional Radiology. Thank you very much.
Thank you, Dr. Hetta. Any question? If not, I re-invite Dr. Cizman to come